Dear friends, dear colleagues, I would like to thank Professor Vasilios Kotsis for his kind invitation to participate one more year in this fantastic meeting. So my task is in the next 20 minutes to talk about the dual and triple combination-based strategy for cardiovascular prevention in patients with hypertension. And I want to start with the first slide of our current guidelines that were published in past June in Milan. So our guidelines recommend the strategy, the treatment strategy based on the global cardiovascular risk of the patient. So in this sense, what happened with subjects with high normal blood pressure, in which the risk may be very different depending the associated cardiovascular risk factors and the presence of hypertension-mediated organ damage or the presence of symptomatic cardiovascular disease. Well, the evidence we have is based on the meta-analysis of Thermopoulos, in which in these patients or in these subjects with high normal blood pressure, only patients at high or very high risk had benefit of the of hypertensive treatment, of antihypertensive treatment, in reduction of stroke and the composite of stroke and coronary heart disease. But in addition to the meta-analysis, the paper of the HOPE-3 trial, which primary endpoint was a composite of cardiovascular death, non-fatal MI, and non-fatal stroke, in subjects at low or intermediate cardiovascular risk, you may see that in this very important trial, subjects in high normal blood pressure values didn't have any kind of benefit of receiving treatment with a combination of an ARB or hydrochlorothiazide. Even with close to 9 years of follow-up, the results are exactly the same. No benefit in subjects in high normal blood pressure and low or moderate cardiovascular risk. For this reason, our guidelines recommend that in adult patients with a history of cardiovascular disease, predominantly coronary artery disease, drug treatment should be initiated in the high normal blood pressure range, but is the only group in which this recommendation applies. Patients at very high risk. What happened with grade 1 hypertension patients? Also, in this group of patients, there is a very important difference in global risk depending on the association of other risk factors or cardiovascular disease. Our guidelines said in low risk grade 1 hypertension, a very small increase of systolic blood pressure without any kind of hypertension-mediated organ damage, or in very old octogenarians or frail patients, a physician may select, in addition to lifestyle interventions, between low-dose monotherapy or low-dose combination of two drugs, because the blood pressure target to be achieved in this group of patients is very low, is below 130/80. This is based on the evidence we have that in patients with grade 1 hypertension, there is the antihypertensive treatment reduces stroke, coronary heart disease, the combinations, and all-cause death and cardiovascular death. In addition, as I pointed out in a few minutes, the HOPE-3 trial also showed that in patients with low and moderate risk in grade 1 hypertension, treatment with a combination of two drugs, ARB plus hydrochlorothiazide, was very effective in reducing the composite endpoint, the primary endpoint of cardiovascular death, non-fatal MI, and non-fatal stroke. For this reason, our guidelines said in patients with grade 1, even in grade 2 hypertension, asymptomatic, without any kind of cardiovascular disease, silent or clinical, first is to be sure that this is grade 1 hypertension, true grade 1 hypertension. So the recommendation is repeat office blood pressure or use home blood pressure monitoring or ABPM 24 hours monitoring, in order to be sure that the patient has, in fact, grade 1 and not a white coat effect. Once the diagnosis is perfectly established, initiate lifestyle intervention. And if blood pressure is very low and below 150/95, you can maintain this lifestyle intervention no more than 3 months, and then start antihypertensive treatment if blood pressure is not controlled. For any other patients with blood pressure values higher, this cutoff 150/95, immediate drug treatment is recommended with the aim of optimal control of at least 3 months. In patients with grade 1, 2, or 3, but symptomatic or with silent disease or with clinical disease, the recommendation is start immediately lifestyle intervention with antihypertensive drug treatment. The recommendation of our guidelines is very clear. Start with dual combination therapy in most patients, in the vast majority of patients, using a blockade of the renin-angiotensin system with an ACE inhibitor or an ARB plus a calcium channel blocker or a thiazide diuretic. If with low dose dual combination blood pressure is not controlled, increase to full dose if patient tolerates the increase of all doses, because we can achieve about 60% of subjects with controlled blood pressure using this strategy. If this is not enough, the next recommendation is the triple combination of the 3, blockade of the renin-angiotensin system, calcium channel blocker, or thiazide-like diuretic in a single pill. So this is very important. Single pill combination of 2 or 3 drugs may achieve up to 90% of blood pressure control. In the remaining patients, they have true resistant hypertension, no more about 5%, and you have to consider to consult a hypertension specialist in this kind of patients. Recommendation is very clear. The monotherapy is only used in selected group of patients, low risk and blood pressure below 150/95, or high normal blood pressure but at very high cardiovascular risk, or in frail patients and or advanced age. And beta blockers may be used in these steps as monotherapy or combined with these drugs when there are clinical indications for the use of beta blockers. So all guidelines recommend start treatment with a combination of 2 drugs, different classes in most patients, using a single pill combination to improve adherence. Why? Because combination therapy induces a more important blood pressure reduction. You may see in the pathogenesis of hypertension in the human beings, 3 main mechanisms are involved: the sympathetic hyperactivity of the sympathetic nervous system, hyperactivity of the renin-angiotensin system, or excess of volume, bad management of water and salt. So in human beings, these systems are overlapped. So there are patients in which predominate the sympathetic nervous systems. In other group of patients, the predominance is the hyperactivity of the renin-angiotensin system, and there is a third group of patients in which the volume is the main problem. So it's almost impossible. It's very, very difficult to know in our patient what is the main mechanism involved in the hypertension. So for this reason, when we use monotherapy, we only can achieve in a group of patients about 40% of success, because when we combine 2 or more drugs, the percentage of combination, the percentage of blood pressure control increases. So this is the main reason, the pathophysiological reason to recommend dual combination, and when dual is not enough, triple combination to achieve blood pressure control in the majority of patients. The evidence show this data in this meta-analysis of 147 studies, using including more than close to 500,000 people. You may see what happened with the reduction in monotherapy of 10 millimeters of mercury of systolic blood pressure. In fact, there is a significant reduction in coronary disease and in stroke, but this reduction is much higher when we achieve a higher reduction, about 20 millimeters of mercury, using dual or triple combination. We have this very recent paper published in JAMA. It's a meta-analysis of 7 randomized clinical trials involving close to 2,000 patients, and in which low-dose combination were compared of 3 drugs and 4 drugs versus monotherapy, usual care, or placebo. The primary endpoint was systolic blood pressure reduction. So we may see that in all these triple and quadruple therapy at low doses always was much more effective than monotherapy or the usual care. So all these data supports the recommendation of our guidelines, starting treatment in most patients with dual combination and then go further to triple combination when blood pressure is not controlled. The second point is that in addition to inducing a more important blood pressure reduction, there is a reduction of the individual side effects. All you know that the use of the dihydropyridinic calcium channel blockers, they are potent vasodilators. They increases heart rate. There is a reflex tachycardia, about 5 to 10%. But this side effect may be compensated with the combination of a beta blocker. So the combination of the dihydropyridinic calcium channel blocker and a beta blocker normalizes the reflex tachycardia, and even is compensating the perhaps excess of reduction of heart rate induced by the beta blocker. When we look at the most common side effect of the calcium channel blocker with the dihydropyridines, that is ankle edema. This is due to the preferred vasodilation of the precapillary area induced by the calcium channel blocker. But when this drug is associated with another second drug inducing a vasodilation of the postcapillary, perhaps the use of a blockade of the reangiotensin system, there is a minimization. So there is a reduction in the leak of water through the capillary area. So there is a reduction in the individual side effects, but unfortunately, it's only a minimization, is not the disappearance of the side effect. Third point is that improved therapeutic adherence. It's very well established that the number of pills matter. And in this study, you may see in different populations that the increasing number of pills is associated with an increasing percentage of bad adherence. So one of the aims of the recommendation of our guidelines is to reduce the number of pills, ideally to 1 single pill. When we performed this meta-analysis and systematic review that was published in 2031 in hypertension, I can show you that comparing single pill combinations with 3 combinations of 2 drugs on adherence and persistence, you may see that in the dark blue, close to 80% of subjects, adherence was much better in using single pill combination. Also, persistence on medication was close to 90% in single pill compared with 3 pill combinations, and also reduction of systolic and diastolic pressures and blood pressure control was higher, significantly higher using single pill combinations. The combination of more important blood reduction of blood pressure, the improve in therapeutic adherence, which permits achieving earlier blood pressure control. You may see in this study what happened comparing initial combination therapy with monotherapy and then add-on depending on blood pressure control. And you may see that even at 6 months of treatment, there is a significant difference, 8% significant difference in reaching blood pressure targets. So no doubt that starting with combination therapy is much better, permits an earlier blood pressure control compared with monotherapy. This is important because in this same study, you may see that comparing initial combination with late combinations, when we see significant reductions in acute MI, in hospitalization for heart failure, and all cardiovascular events. Even all-cause mortality is reduced in patients with good adherence compared with patients with poor adherence. You may see that adherence to antihypertensive treatment may reduce close to 30% all-cause mortality in subjects. This is true also in patients with frail patients, in the elderly. In this study in the Lombardy region by the group of Professor Mancha, all-cause mortality was assessed in a group of more than 1 million frail elderly individuals, comparing what happened depending on the percentage of adherence to the prescribed treatment. In 3 subgroups, good clinical status, poor, and very poor clinical status. You may see that subjects having more than 75% of adherence were those reducing all-cause mortality, even independently of the clinical condition for good, for poor, and even for very poor clinical condition. So, adherence is very important, and at the end, the use of combination therapy, when we compare with monotherapy in this analysis, this meta-analysis of Thermopulos, you may see what happened. Increasing the number of drugs, there is a progressive reduction in the cardiovascular events, in congestive heart disease, in coronary heart disease, stroke, heart failure, and the combinations of these events, and also cardiovascular death. So, in summary, our guidelines recommend to start treatment in most patients with 2 drugs, not 1. This is the key message of our guidelines. Initial therapy for the majority of patients with hypertension should be with a combination of 2 drugs, not a single drug. There is an exception. The exception would be a limited number of patients with low risk and grade 1 hypertension whose systolic blood pressure is modestly elevated, less than 150, or very high risk patients with high normal blood pressure, or in very old and frail patients due to cautionary reasons. Single pill strategy to treat hypertension. In addition to the use of a dual combination to start treatment, perhaps in the future, a triple combination, the single pill strategy is crucial. Poor adherence to blood pressure medication is recognized as a major factor contributing to poor blood pressure control rates, and research shows a direct correlation between the number of pills and poor adherence to medications. And single pill combination therapy improves adherence to treatment, as I showed you. Single pill therapy is the preferred strategy for initial dual combination treatment of hypertension in most patients, and also for triple therapy. That's all. Thank you very much for your attention.